Hello and welcome everyone for another edition of the Hindus Wellness Series. Thank you for joining us on this Sunday morning. This edition of the webinar is presented by Kauvery Hospitals. We will be discussing an important topic today, advancements in cardiac therapy, implications during COVID-19. We all know that cardiac illnesses are one of the major disease burdens. While there are already several issues in getting medical attention at the right moment for cardiac illnesses, COVID-19 has made it even more complicated. While on the one hand, the pandemic has made it difficult to access healthcare for other illnesses, we also hear about COVID-19 induced cardiac illnesses. To discuss this topic, we have two eminent doctors from Kauvery Hospitals with us today. We have Dr. R. Anantharaman, Senior Consultant Interventional Cardiologist at Kauvery Hospital in Chennai. He has over 22 years of expertise in dealing with cardiac diseases. He has interventions. His areas of interest include hypertrophic cardiomyopathy, transcatheter heart valve therapy, advanced heart failure and transplantation, stem cell therapy, and rotablation. Welcome to the webinar, Doctor.
Good morning. Thank you.
We also have Dr. M. Rajendran, who is Consultant Interventional Cardiologist at Kauvery Hospital in Salem. He also has over 2 decades of expertise in cardiac-related illnesses. He did his MD in Stanley Medical College, followed by DM Cardio in Madras Medical College. He has published 2 papers in international journals. His areas of interest include peripheral angioplasty, renal angioplasty, dual chamber pacemaker, and ICD implantation. He was awarded the Rising Star Award by Times of India in 2019. Welcome to the webinar, Doctor. So as with our other webinar series, so this is the pattern we'll be following for this webinar as well. Each of the doctors will be making a presentation for about 15 minutes, following which we will be going to question and answers session. We will take questions from audience. So to begin with, may I invite Dr. R. Anantharaman to make his presentation. Over to you, Doctor.
Good morning. Thank you, Panvasan. And firstly, I'd like to thank Kauvery Hospitals as well as the Hindu Wellness Series for this fantastic opportunity to share our experience of how we dealt with this cardiac issues during this COVID pandemic and how this advancement in therapies have really changed in terms of patient management as well as the outcomes. Now, the COVID-19 and heart, obviously, COVID-19 pandemic as such has changed the way we live totally. A new norm has been created on how we live and how we also practice medicine as well as surgery. Now, patients who already have pre-existing heart disease were more severely affected when they had COVID. And there was a lot of fear coming to hospital for these patients acquiring COVID. They suffered at home. Some of them had heart attacks at home and died. But when they presented with COVID to hospital, they had multiple issues. Some of them had heart attacks. Some of them had a heart failure. The COVID also affected the muscle itself, called myocarditis, some arrhythmias, some sudden death. We have seen a lot of that in the press, and also a lot of clots, both in the veins as well as the arteries. Now, there was a lot of demand for beds, intensive care beds, ventilators, oxygen requirements, drug requirements, and staff reallocation, which meant we were not able to practice in the normal way, especially cardiac surgery and availability of cardiac surgical beds, and also allocation of ICUs as well as oxygen. So we had to adapt to a new mode and a new model of therapy for these patients, because these are high-risk patients. Without treatment, their death rate is very high. So the alternative was to adapt transcatheter procedures or minimally invasive procedures, which will reduce their overall risk, at the same time reduce their hospital stay, reduce the infection risk, and then get them home as soon as and effective treatment. So that was what was followed during this COVID-19 pandemic. I will touch upon some very important aspects, these 4 aspects of advancements in cardiac therapies, which has made a huge difference during this COVID pandemic in our cardiology practice. One is this transcatheter valve therapies, And second one is laser angioplasty, which is currently available only at Kauvery Hospital in Chennai and only 4 places in the whole of India. Again, hybrid surgery. Again, for doing hybrid surgery, you need to have hybrid operating room where you can do surgery as well as intervention, which is available only at Kauvery at the moment. And then mechanical circulatory support, which is implanted just through the vein, percutaneous arterial. So these things made a huge difference. First, I'll touch upon this transcriptive valve therapy. What is it?
Option for people with symptomatic severe aortic stenosis that does not require open heart surgery. Severe aortic stenosis occurs when the aortic heart valve does not open and close properly. This makes your heart work harder to pump blood to the rest of your body. A diseased valve affects your health and limits your daily activities. Before the procedure begins, you will be given anesthesia or a mild sedative to make you comfortable. The entire procedure typically lasts between 1 and 2 hours. The arteries in your body are like a system of roads that branch out from the heart. There are different routes that your doctor can use to implant the Medtronic TAVR heart valve, and all come with their own individual risks. These routes include an artery in your leg, an artery in your neck, and a space between your ribs. Speak with your doctor about which route is best for you. In a typical Medtronic TAVR procedure, the doctor makes a small cut at one of these access points and guides a thin, flexible tube with the TAVR valve into your artery and to your diseased valve. When the TAVR valve reaches your diseased valve, the features of the Medtronic heart valve allow your The self-expanding frame of the Medtronic heart valve enables your doctor to deploy it in a controlled and accurate manner. After expanding, the new Medtronic TAVR valve takes over the old valve's function to help blood flow efficiently out of the heart. To complete the procedure, the thin, flexible tube will be removed and the cut will be closed.
So the conventional surgery for valve replacement is open surgery or minimally invasive. But this transcatheter surgery, as mentioned in the machine itself, should last about an hour maximum. The patient can be discharged even the same day or say without. So it's an 81-year-old. This was the first case in India of a valve in valve. This was done in 2015 just to show multiple comorbidities, cancer, other issues, previous valve surgery, which failed. Multiple hospitals were visited, unable to receive any treatment. And being this was the first case in India, we were also very wary and had a lot of support. Now the tube was placed in the groin wire, and then the valve was taken. This is the previously placed valve which is failed. And through that, the new valve was placed. As soon as the new functioning immediately, and the patient feels better. So this was the first of its kind of its procedure. And it was covered in most of the national press in all languages to increase awareness of this kind of procedure. So this was in 2015, first valve in India, was performed under our team. Since then, we have performed several of these procedures, and during COVID time, I have traveled to about 10 different cities, helping my colleagues as well to perform these procedures and save lives. More than 30 such procedures. It's just not Chennai alone. During this COVID time as well, we have traveled and helped the other centers to do this. So this is a significantly life-saving procedure. So second one is the laser angioplasty. So what is laser compared to other angioplasties? So this animation will tell you what the laser is.
Spectranetics laser atherectomy catheters are uniquely designed to safely and effectively treat the full spectrum of morphologies present in peripheral obstructive disease, from de novo atherosclerotic plaque with and without medial calcium to total occlusions and soft restenotic lesions. The unique photoablative properties of the cool excimer laser technology have been shown to both debulk the lesion and improve vessel compliance while minimizing potential damage to the surrounding vessel. This is accomplished through 3 non-mechanical mechanisms of action. The photochemical action of the laser's ultraviolet light uniquely targets the chemical bonds within all morphologies of the lesion, breaking up the plaque at the molecular level, allowing the photothermal action to soften the lesion and facilitate greater compliance. The laser's photomechanical action captures the kinetic energy created by the vapor bubble to break through hard fibrous lesions. These three mechanisms of actions combine to power through the majority of PAD lesion while minimizing the potential harm to the vessel wall and an increased risk of embolization.
So this is again a new technology which is available only in 4 centers in India, and in Chennai it's only in Kauvery. Now, this laser makes a huge difference in terms of treating these patients, especially COVID time. This is a 52-year-old gentleman from Calcutta, businessman visiting Chennai, had a major heart attack and then came with a heart attack. Now, the patients, when they presented with heart attack during COVID, they had a lot of blood clots in the heart blood vessels. And the conventional type of treatment we were doing, that is removing clot or ballooning, all those things didn't work. So this was an artery that was blocked. The front artery was completely blocked. Right artery was okay. So the conventional treatment is the wire, and then we are aspirating the clot, which hasn't worked. Ballooning hasn't worked. Still the blood vessel in the front is still blocked with a lot of clot. Then the lasering was done. This was lasering from top to bottom. So that is a lasering procedure. After that, the blood vessel fully opened up. The blood started flowing. Where I am showing the marker, the blood started flowing. And the patient survived. Without this, the patient would have died. He survived and he went back to Calcutta after 4 or 5 days after all the support were removed. Again, this was a life-saving procedure, and this we are continuing to do the laser-assisted angioplasty at Kauvery now, and saving a lot more lives. Now, the next one is hybrid. What is hybrid? It's like you think about hybrid cars, and hybrid says you're combining surgery with intervention. What is the need for this? First thing is the conventional bypass surgery. You are bypassing the front artery with the artery that is present in your chest wall, that is the mammary artery. Other arteries that goes to the back of the heart or the right is bypassed using veins from the legs. You are removing the veins from the legs and then using a new channel to do this. Now, this mammary artery stays longer, 15 years, 20 years, they are very good. But these veins that are used, about 40 to 50% of them block by 10 years. Instead of that, if you use stents, they last longer. So combining this mammary artery graft and stenting procedure is what hybrid is. So that is the important graft and stent. To do that, you need to have a hybrid operating room if you want to do it in same procedure, the surgery as well as the stenting procedure. Unfortunately, we have that in. I will put the bypass graft. Following that, I will put a stent, and both are completed. Now, the outcome, I said, the mammary arteries, 90% will be open by 10 years. The stent will be about 85% will be open by 10 years. So you're giving the best of both. The vein graft, about only 60% will be opening. So combining the best two worlds is what the hybrid procedure is. And also the other advantage is you are avoiding this major sort of surgical trauma and also prolonged stay in hospital and reduced infection. A much safer procedure. So this was one during this COVID time, September 20, 44 male, previous coronary artery disease, previously thought not operable in another centers. So he came in, he had blocked artery in the front and he had narrowed artery in the right. So the surgeon did the bypass first through the small incision in the left, and then I went ahead and put a stent on the right side. And the patient did well and discharged on 3rd day. So that is the major important aspect during COVID time. And this was the first procedure of its kind in India, combined hybrid procedure for bypass and stenting. And so 30 such procedures have been done in the last 15 months. And it is a life-saving procedure again. The last one is this circulatory support. What is this? When the heart is affected, the heart will not pump. So you need to support the heart with an external device. And how we do it is with a small pump.
The Impella is the world's smallest heart pump. The cardiologist places the Impella heart pump into position using standard cardiac catheterization techniques, inserting the catheter into the leg artery and guiding it into the heart. Once in place, the Impella pump is turned on, providing support to the heart while monitoring the pumping activity. The Impella pump mimics the natural pathway of blood flow from the heart to the ascending aorta, increasing blood pressure while unloading the heart and providing more blood supply to vital organs such as the brain and the Impella is the world's smallest aorta, increasing blood pressure while unloading the heart and providing more blood.
So basically, it does the work of the heart, main pumping chamber. It sucks out the blood, puts it in the, and this is a fantastic thing to save patients. This is one of the kind first case of Asia Pacific, whole of Asia Pacific, where an 18-year-old was affected with myocarditis due to COVID. He had out of hospital cardiac arrest, resuscitated. He was brought in, and the heart function was only 10%. So he had this Impella done. That was the Impella placed. This was in June. Next day, the heart started recovering, and the third day, the heart was almost normal. And fourth day, the heart function was 50%. So the Impella was removed. So without this, that boy would have definitely died. So these kind of advancements in technology and availability and in a center of excellence with a fantastic facility has helped us to save many more lives. And the heart recovery program is taking structure now at Kauvery with a good team. So COVID pandemic has created a new norm for all of us, and the advancements in cardiac therapies, as shown a few of them today, has helped to save many more lives. And the world-class facilities we have at the moment at Kauvery is helping us to do this. And the Hindu Wellness Series has been a welcoming platform to increase awareness to patients and to take these developments and so that the wider population can benefit from this. Thank you, Panas. So please get vaccinated, all of you, because that is the one that saves you all. Thank you.
Sorry, doctor, I was on mute. Thank you. Thank you so much for that wonderful presentation. You elaborated in very layman terms on the latest technologies that are available and treatment procedures for cardiac-related illnesses. Thank you, doctor. Now, may I invite Dr. Rajendran to go ahead and make his presentation. Dr. Rajendran, over to you.
Thank you, sir. Yes. I first of all thank Kauvery Hospitals and Hindu for organizing such an event to create awareness towards the public. And thank Dr. Anantharaman sir, who has done a fantastic job. India's first hybrid revascularization and India's first valve-in-valve TAVI. So with this, I'm proceeding with my topic, advancements in cardiac therapy and COVID-19 implications. When it comes to new age technologies in cardiology, there are some few things I want to mention. So artificial intelligence is one thing that has penetrated almost every field of science and technology. What once was a science fiction, now in reality. Artificial intelligence algorithms are almost used in many cardiac interventions like echocardiogram, cardiac CT, and cardiac MRIs. These algorithms physicians to make precise measurements with optimal windows in echocardiogram and also in calcium score calculations.
Doctor, we're not able to hear you.
Can you hear me now?
No, doctor. Are others able to hear?
No, the audio is not.
Yeah.
Voice is very feeble.
It's okay now?
No, doctor.
about now? It's okay?
It's still very feeble, doctor.
Okay.
Feeble, but bit better, doctor.
Now it's fine now?
Yeah, it's fine. It's fine.
Okay.
Yeah.
So the other thing is the transcatheter interventions. Just now, Dr. Anantharaman has briefed much about it. And the other thing is the wearable devices and patient monitoring, 24/7 health tracking. It provides insightful information, especially in emergencies. For example, if a patient develops sudden irregular heartbeats, this can be appropriate action can be initiated without the patient has to reach the hospital. And the other thing is the miniature ventricular assist devices, as what Dr. Anantharaman has just now talked about, the impeller-like devices. So if it comes in miniature sizes, it will be much useful to handle it better and make it safer and less infectious, and to cut down infections and thrombosis. And also portable and small ECMO devices is around the anvil. Also magnetic navigation and robotic systems, especially more useful in electrophysiological lab to precisely locate the arrhythmia focus and do radiofrequency ablations. The other thing is stem cell therapy in heart failure. And the last but not the least, intravascular imaging and interventions like intravascular ultrasound, as well as OCT, what is called as optical coherence tomography. So what is OCT? The OCT is nothing but it is a diagnostic procedure in catheterization laboratory. It uses light waves and camera inside the coronary blood vessel. So you can see the arteries as how you can see it under a microscope. It has got a very high image resolution. So the decisions regarding usage of stents and balloons and the length of the stent, the diameter of the stent can be precisely decided. It helps also to decide upon how much fat is located inside the blood vessels and the size of the blood clots, whether it is fresh or older, that is clogging the artery. Also, this OCT helps in perfect assessment of the length of the stenosis, that is obstruction of the blood vessels, and the diameter of the stenosis to select your stent length and diameter. So this technology makes sure there is a proper expansion of the stent and good apposition of the stent inside the blood vessel. So this kind of technology is much more useful in complicated coronary interventions like bifurcations and the left main interventions. So this OCT console, it has got a console and imaging catheter. It employs a fast image acquisition with a 7.5 centimeter pullback in 2 seconds. So if you take a look at this, this is a coronary artery. It has got, this catheter has got 3 radiopaque markers. This helps us to cross the lesion and place the lens inside the blood vessel to exactly locate where the lesion, the length of the lesion. So I have a case presentation today in case of a previously stented patient who developed again another heart attack. So this patient has got heart attack in 2020 March, and he presented with right coronary artery stenosis of 90%. He was stented in a good health and he went back home. But he again presented with another heart attack and the ECG showing the same territory of involvement, what we call it as instantary stenosis. Despite a stent in place, he developed another heart attack because of a new block occurred in the same stent. So this is the video. You can see there is block the middle of the artery, almost 90%. So I wanted to proceed with using this technology. The wire is passed across the stenosis, and this is the OCT. So OCT is nothing but a lens placed in the wire that will be placed distal to the stenosis and will be pulled back automatically. While getting pulled back, it records images circumferentially to see what's happening inside the lumen as well as surrounding the blood vessel wall. So we can assess the length, the diameter of the stenosis as well as content of the blood vessel wall that is causing the obstruction of the blood vessel. So this is almost like a histological cross-section, what you see a biopsy specimen under the microscope. So with the conventional angiogram, you see only the two-dimensional view. Your decision making will be totally biased because of limitations of conventional angiogram. But using this technology, that is intravascular imaging, what is called as OCT, we can precisely locate the lesion and decide the length of the lesion, the diameter of the lesion, also the content of the lesion precisely, and make informed decisions that can be translated better into the patient's management. This is a picture showing inside the blood vessel wall. You can see this is what is called a small apposition, because the original stent that was placed 1 year back was not well apposed close to the vessel wall. A stent is a metal mesh that is supposed to closely adhere to the wall of the vessel. But this can be made sure unless you use intravascular imaging. In conventional angiogram, you cannot make sure whether the stent is well opposed to the vessel wall. Because we used intracoronary imaging, we can very well make out the stent is not adhering to the wall of the vessel. So this is a malopose stent. And this is the reason why he developed stenosis again after stenting. So this is the tissue, instant stenosis. This is predominantly made up of fibrofatty plaques. This is a proximal segment of the vessel, the distal segment of the vessel, just distal to the stent and proximal to the stent. So we can see the difference between the normal vessel and the diseased vessel. The normal vessel have a triple layered appearance, whereas the abnormal vessel will have disturbed the triple layered structure. Based on that, we'll select the length of the stent. And after assessing the lesion with OCT, we did balloon dilatation to prepare the site. And this is the post ballooning. So after post balloon dilatation, this looks better, but still there is some stenosis. And we did post balloon OCT again. This is a pullback from the distal to the proximal. And the luminal stenosis has to some extent improved because of the balloon dilatation of the stenosis. And there are minor dissections, that is tearing of the inner wall of the blood vessel. So all these things can be perfectly made out if you use this intravascular imaging. Also, presence of calcium surrounding the vessel wall also can be specifically made out. If there is a strong calcium, we may have to use stronger balloons to adequately prepare the lesion. This is the post dilatation OCT. And this is the stent that is placed across the stenosis after choosing the ideal length and diameter with the help of the OCT. And the stent is deployed now, that is expanding. After stenting, this is a post-stenting check angiogram. It looks very good. The stenosis is almost treated by conventional angiogram, but I wanted to check it with the OCT, whether the stent is properly positioned. I did this OCT, even though I'm convinced with coronary angiogram. I'm doing now this OCT. The stent is closely adhering to the vessel wall from the distal side. It's coming to the proximal side of the stent. It is perfect, perfectly matched. But as it comes closer to the proximal part of the stent struts are not well opposed to the vessel wall. So this is particularly made out just because of using this technology. In the conventional angiogram, it was looking good, and also there is a big clot beyond the stent. So this was made possible by using this technology. So after finding this proximal stent was not opposed with the wall, so I used another balloon to dilate. So after dilatation, this is the picture. Now it is looking better. So the final OCT picture. Yes, there is a, so the stent area and the luminal area is matching better. That means there's a good expansion of the stent. We expect usually more than 90% expansion of the stent throughout the length of the stent. And the proximal mall of position was addressed well with the balloon dilatation. And also there was a thrombus proximal to the stent that was treated medically. So this was a blood clot that was very much evident. So this is the final OCT. So this is the pre-stenting picture. This is the post-stenting picture. So you can make out the difference. So that was one of the advantage, one of the new age technology that was used. Coming to this COVID, how COVID-19 had its say in cardiology. So we had a lot of difficulties, as Dr. Anantharaman has told. It is very difficult to have adequate cath lab personnel, because some people have to be in quarantine, or some people will be dispatched to other departments. So we have to do our work with the limited personnel. And the choice of management was also deferred because we cannot choose intervention treatment for every patient. For less severe patients, we used to treat them medically. For more severe patients, we used interventional treatments. And as it was discussed earlier, the bed availability was very difficult. It was almost every hospital was flooding with COVID patients, and delayed presentation was also a problem. And because we delayed presentations and the delayed door to balloon time was also a problem for us. And the personal protection from COVID was also a bigger issue, and wearing those tight masks and aprons and doing procedures. I don't know how Dr. Anantharaman managed all this stuff. Doing transcatheter procedure is a Herculean task, and wearing all this personal protection, the aprons, and doing enduring procedures is quite tough job. And another difficulty is the myocarditis mimicking a STEMI most of the times, because we cannot rely on biomarkers, because both diseases can behave same way. I have one case with myocarditis. It's typically behave like interval MI, and I found coronaries were normal in the cath lab. Also, patients, COVID patients presenting with STEMI is also problematic. We cannot intervene them as how we did in the past. So despite all these oddities, many doctors raised to the occasion and offered their best. So I thank every one of them and my dear fellow colleagues and frontline workers who battled this COVID efficiently. Thank you.
Thank you so much, Doctor. You rightly said, I mean, we would not have come out of this pandemic if not for the doctors and other frontline workers who did a fantastic job. Thank you so much for your presentation. So we will move on to the question and answer session now. We have few questions coming up from the audience. But before that, I would also like to pose few questions to you, doctors. Dr. Anantharaman, I mean, we spoke about cardiac illnesses. Now, post-COVID, we also hear often about COVID-induced cardiac illnesses. We hear that, COVID-19 can result in blood clots. And we also read that, certain predisposing conditions can worsen because of COVID-19, because of if somebody gets affected with COVID-19. So in your experience, I'm sure you must have come across such cases. So what is the scenario, and are there any precautions that COVID-19 affected people can take to prevent, from getting affected from any of these cardiac related difficulties? Dr. Anantharaman.
Yes, that's a fantastic question, Panos. Now, the COVID, there are two aspects to it. One is initially when they present with COVID, how bad was that? Whether they had no symptoms or less symptoms or severe symptoms. But subsequently, after that, the post-COVID kind of complications or issues doesn't seems to be really sort of correlating with how they were with the initial COVID. That is one thing that is surprising, and also people should be wary of. They should not think that I had only mild COVID or only very few symptoms, and only people who are admitted to hospital will have issues, because we have seen people with less symptoms, but subsequently after 1 month coming with myocarditis. So I had patients coming with myocarditis after 1 month, or with other problems, like as you said, blood clots in the arteries, blood clots in the veins. When you have blood clots in the veins, it will travel and go to the lungs and gives blood clot in the lungs. That is a serious condition. And one such patient had everywhere clots in the veins, lungs, clots in the arms, legs, spinal artery, brain, but in spite of, and also kidney arteries. In spite of all this, he is recovered, but he had only mild COVID. He was at home and he was having mild COVID. So this is the kind of thing we are saving. And that's why we are running a post-COVID recovery clinic. Irrespective of how the symptoms were, they should come at 1 month to have a complete checkup, including cardiac. And we are picking up asymptomatic myocarditis, arrhythmias, like irregular heartbeats, and all different issues. So they should have one review. The next thing is they should have vaccination. They should not think I had COVID, so I'm protected and it's all done. That's not the case. After around 8 to 12 weeks after their COVID illness, they should have vaccination, because that is what gives further protection, especially when this time the RNA virus keeps on changing. So the Covishield or Covaxin, whatever is available, you should have vaccination, even if you had COVID. That is very important.
So if I understand you correctly, doctor, there is no correlation or clear correlation that we are able to see between the severity of COVID-19 illness and the symptoms that they may have after that. So it is always better to get a review done after 1 month.
At least. Yes, absolutely.
And the vaccination, I understand that, some people who are already undergoing treatment for cardiac illnesses may be skeptical about taking vaccination. So would you suggest that even they should go ahead and take whatever vaccination is available to them, doctor?
They are the ones who should take it. They are the ones who should take it, definitely. Because if they get COVID, people who already had cardiac illness or other long-term illness, they get severe COVID. Now, what we have clearly seen is patients who presented after 2 doses of vaccine, even if they had other problems in the past, heart or neurology or whatever it is, they're not having serious illness. They're having a fever for 1 or 2 days and then getting discharged. But people who did not have the vaccine, even if they did not have other comorbid illness, young patients, they are having severe COVID. So definitely the vaccine protects you. And if you have a heart problem, you should have it.
That is very important, doctor. Thank you. Dr. Rajendran, I would like to pose this question to you. In our country, one of the problems that we face is the health-seeking behavior of the people. People proactively going out to the hospital for taking regular health checkups or things like that is not very common. That is particularly worse in, semi-urban or rural areas. I mean, since you are practicing in a tier 2 city in Salem, how difficult was it for you to handle the COVID-19 challenge? Because many people would have hesitated visiting hospitals during that time. So post-COVID, did you see a spurt in cases? You also spoke about, myocarditis presenting.
Almost most of the patients didn't turn up because of the fear of COVID, contracting COVID. Especially cardiac patients, elderly patients, they are very much worried. Also, the patients' family members also worried to bring them to the hospital. Those patients, we had only video sessions. These patients sometimes presented with symptoms, but presenting late to the hospitals, and that was a difficulty. The most of the time, some patients developing non-cardiac chest pains are rushing to the hospitals also happened out of fear. There was a fear syndrome prevailing in the society. The right symptoms were not addressed properly. So inappropriate symptoms were perceived as serious symptoms, and they were approaching the hospitals, and real heart attacks most of the times were delayed. These kind of things are really happening. And post-COVID, during the COVID, definitely across the globe, I think there is a decline in cardiac cases presentations because of the fear, one thing, and transport issues, maybe the other reason. And this COVID has overshadowed the other illness also. Not only cardiac failure, cardiac diseases, other diseases also was overshadowed by the COVID presentations. Just after the wave, third wave or second wave, the spikes, there was a surge in cardiac presentations. So many heart attack patients, there was a great upsurge in presentation of STEMI as well as NSTEMI to the emergency departments following this.
Even in Salem Hospital?
Yes, definitely. Even in Salem. Right. We have a huge difference during COVID and post-COVID.
Right. Thank you so much, Doctor. Dr. Anantharaman, you spoke about the laser coronary arthrectomy that is available. You said, in the southern part of the country, it is only available at Kauvery hospitals. I mean, from the way you explained and from whatever I could understand from it, it looked like a game changer. It it appeared to me that it makes the use of stent unnecessary with this procedure, if I am right. We have a question from one of the viewers, Mr. Loganatha Prasanna Subramanian. He is interested about knowing about this procedure in detail, and he is asking in laser angioplasty whether stent will be placed. Can you talk more about this procedure, doctor?
Yes. Now, the laser, as it showed, it works through 3 ways, and it will ablate the tissues on its way. It's a cool laser, so it will ablate cholesterol. It will also ablate thrombus, and it will also ablate calcium. So these are the 3 things that will be present inside the blood vessel when you have blockage. And sometimes it is separate and sometimes it's a combination. So if you had only thrombus, especially in COVID situation, we had only blood clot, thrombus inside the heart artery, then just doing the laser and ablating is enough. We don't need to place stent because it will ablate the thrombus and you will restore the blood flow. If you had cholesterol deposition, and if you have ablated enough, and if there was enough lumen, and if you've done an image like Rajendran sir has shown, if there is no residual stenosis as such, you can leave it. Calcium also can be modified with this because basically it breaks the chemical bonds, whether it's calcium or cholesterol, whatever it is. But in certain patients, you have to place a stent. If there is a lesion that is narrowing, which has got cholesterol and calcium, after modification with the laser, you can place a stent properly. Otherwise, if you place a stent, it will not open fully. So in that cases, we use laser, we modify it, we do the imaging, OCT or IVUS, see that, place the right stent, balloon it, and then repeat the image and make sure that we have placed it properly. So these are the three different things. So in some cases, you can get away without stent. In other cases, you will need stent. But it is a game changer, yes.
And is it becoming more common in Indian hospitals, doctor? Is it becoming more affordable as well to Indian patients?
There are two things that makes it a little bit difficult of availability in a lot of centers, because one is the machine itself. I've not shown the picture. The laser console, which produces a laser, it is about 300 kilograms weight, huge machine.
Okay.
So it is not something it can be transported from one cath lab to another or one hospital to another. So that is one thing. The second thing is the cost of the catheter. At the moment, it is expensive, but it will come down over a period of time.
So once we start using more, the price will come down as well. Dr. Rajendran, you made an interesting observation about the use of artificial intelligence in treating these illnesses, and you also spoke about wearable devices, which is becoming more common now. In your experience, can you tell us, what sort of wearable devices that people can use, and how can that help in, monitoring our cardiac health and getting alert at the right time to seek healthcare?
So artificial intelligence is definitely much more useful, especially in the wearable devices, which employs artificial intelligence algorithms, particularly for patients with arrhythmias. So the arrhythmias are nothing but irregular heartbeats, which either can go slow or faster. If the heart rate is going for more than 200, suddenly the patient might feel giddy or may fall down. Sometimes he might lose life. So this can be prevented by immediately giving him the treatment. But this may not be possible if it is not diagnosed at an appropriate time. So this can be prevented by wearable devices. So if they are showing some arrhythmias, suppose before proceeding with the typical arrhythmias, they may have small clues like abnormal few beats that can be picked up earlier, and appropriate action can be initiated there itself. So by this technology, so this can be used in wearable devices where the patients can be benefited much more.
Thank you, Doctor. Thank you. We have a question from one Mr. Balachandran. He is asking, I'm putting for the question as it is. Dear doctor, I am planted with ICD 4 years back. What are the precautions to be taken during this COVID pandemic? Can I do light stretching exercises? Can the battery be replaced with a new one? He has also asked his age is, he has also mentioned that his age is 64. Could the ICD dual chamber be removed after the battery is fully discharged? At present, I'm doing fine.
I'll take this in three parts.
Okay.
The first thing is about the diet and exercise. This applies to all patients, all cardiac patients during COVID time. A healthy diet is important and high in vitamin C. Exercise is important. It will increase your immunity. And continuing the regular cardiac medicines, even if you're not able to go for follow-up, don't miss that, because it's very important. Whatever was prescribed before, you should continue, including your aspirin or all the cardiac medicines. So good diet, exercise, continuing cardiac medicines is important. If you have any new symptoms, all cardiac patients, if you have any new symptoms, pain or breathlessness, at least have a video consultation if you're worried about going in-person consultation. So that is about the advice for all of them. Now, with regard to him specifically about the device, he can do exercise, stretching exercises he can do. And usually the first 3 months, we advise not to lift the arm, left arm, if it is placed on the left side above the head, but otherwise he can do stretching exercises. With regard to the last part, usually when ICD, that is defibrillator, is placed, it is placed to prevent sudden cardiac death. So it is for life. And the battery can be changed, because basically it is a small incision. You remove it and change the battery. All the wires will stay the same. So it's a very simple procedure, changing the battery. But it is for life. Once it is done, it is usually done to prevent sudden cardiac death.
Thank you, doctor. The other question, there is one from Ms. Rageshwari that is also somewhat related. She has asked about her father who underwent bypass surgery in December 2019. What precautions he should take and food habits, whether there should be any need for change in food habits during this pandemic. Can Dr. Rajendran, would you like to answer?
Living along the pandemic, the food style has to be the same for any cardiac patient, whether it has got stented or whether it has underwent bypass surgery. They have to follow a typical food style that avoids saturated fats and encouraging high fiber diet and increasing antioxidants like fruits. If he's not a diabetic, he should be at liberty to take more fruits, at least 3 servings per day. This applies to every cardiac patient to keep his health fit. So there is no specific COVID-related food style. For any cardiac patient, whether he's stented or grafted patients, they have to strictly adhere to low fat and high fiber diet, along with the aerobic exercises.
Right, doctor. Thank you. Thank you, doctor. We have covered most of the questions from the participants. Dr. Anantharaman, I also wanted you to elaborate a little about the hybrid procedure that you spoke about as your last focus in the presentation. You said it is very innovative. What sort of patients, how is it suitable for what kind of patients? When should one adopt for such hybrid procedures, doctor?
Now, the conventional bypass surgery, it is done when you have narrowings or blockages in all 3 of your heart blood vessels, or the main blood vessel on the left side, along with the others. Usually, bypass surgery is advised, especially if there are diabetic patients, reduced heart function. Now, the conventional surgery is done with what we call sternotomy. That means the breastbone will be cut open, and then they will bypass one of these mammary arteries to the front, and the others will be taken from the leg and bypassed. Now, this means they will be in ICU for a couple of days and at least 5 days in the ward, so total about 7 days in the hospital. And then the recovery time when they go home, the outside wound heal in about sort of 2 to 3 weeks, but inside bone will take time to heal. It will take up to 3 months at least. But for lifelong, they will be left with wire, sternal wire, which will be there for life. And we have seen various issues with that. Now, the hybrid is minimally invasive. That means you are going through between the ribs on the left side. You are not breaking any bones. And it's a 3 to 4 centimeter incision. Through that, you are still putting the main mammary artery graft, which is the main reason to do bypass. Others use stent. You can do it in 2 procedures if you do not have a hybrid operating room. But because we have the hybrid operating room, we can complete it in 1 procedure. The surgeon will do the bypass. After that, immediately I will go in and check the bypass, whether it's working. That is another major advantage. I will check that bypass to make sure that it's working, and then I will stent it. Now, this has been a very welcoming thing. A lot of patients liked it. And we have done several of this during COVID time, more than 25 to 30 now. Hospital stays, ICU stays only 1 day. And then they go to ward for 2 days. By 4th day, they are discharged. So the stay is less, the risk is less, the infection is less, and they still get the best treatment, best outcome treatment. Mammary artery and stent, 10-year outcome is around 85 to 90%, still open compared to the vein grafts. So all advantages with major advantage during COVID time. Now, the only thing is the expertise. There are not many surgeons who can do this along with the cardiologist. So that will slowly increase. Otherwise, majority of the patients who need bypass can have this. There are other hybrids we do as well for congenital heart disease as well. Surgeon will close a hole in the heart and we will put a stent in the main blood pipe, like coarctation. We have done several of these combinations. Or I will put a valve, transcatheter valve, and surgeon will put a graft. Or I will put a transcatheter valve, the surgeon will do bypass in the leg or for the neck. So all different hybrids have been done. So there are lots of different hybrid operations, which essentially reduces the risk and increases survival at a much better outcome.
Thank you, doctor. We have one question from one Bharat Vaswani. He has asked to Dr. I'll put the question as it is. Is long-term rhythm control therapy useful for a patient who has survived a cardiac arrest?
So he's put my name,
Yeah.
Dr. Rajaram. Long-term rhythm control therapy useful for a patient who has survived cardiac arrest. Now, cardiac arrest is different from heart attack, but
Yeah.
we have to sort of separate it out. Heart attack is when the heart blood vessel blocks, you get chest pain, that part of the heart muscle is damaged. And sometimes during heart attack, you can have a fast heart rhythm and you can have a cardiac arrest. There are other reasons that you can have cardiac arrest when there is not enough oxygen and a sort of chemical disturbance, high potassium, lots of other things. So when cardiac arrest happens, what happens is the electrical disturbance. Your heart beats so fast that it's not pumping out. So you don't get any blood to the brain, and then eventually your heart stops. For somebody who had a cardiac arrest already, the defibrillator therapy is the life-saving therapy throughout their life. So it is a secondary prevention. That means to prevent another chance of having death. Now the rhythm control, what he's asking is, it's a different kind of problem. So from the upper chamber, they will have sort of irregular heart rhythm or a sort of fast and regular heart rhythms. Some of them can be controlled with tablets. Some of them will need a sort of correction with cardioversion or devices. But this cardiac arrest is different. When you have cardiac arrest, when you are given treatment, it will be including a device therapy, that is defibrillator therapy, to prevent another cardiac arrest and sudden death.
Right. Thank you, Doctor. I think we have taken all the questions from the audience. We can bring the meeting to a close. Would both of you like to say any final words, Doctor, before we call off the meeting? Yeah.
Now, obviously, we have come to the pandemic is there, third wave is there, it's sort of impending, it's coming. Our request will be, don't ignore your cardiac symptoms. It is safe to come to hospital. Hospitals have got all necessary precautions taken. You will be treated very safely, because staying at home and suffering, and majority of them can have a heart attack, other issues. So you can receive safe treatment even during this COVID pandemic time. I request all of them to have vaccine, but if they have worsening symptoms, please consult your doctor, please come to hospital, please get the right treatment. And technologies are there to help you to get you home safely very soon. Thank you.
That is so well put,
Rajendran,
Doctor.
sir.
Thank you. Dr. Rajendran?
Yeah, this pandemic, we see a lot of restriction in physical activities because people can't reach, take to their streets or parks. That cannot be an excuse to stay away from exercise. They can start doing aerobic exercise in the home itself. In my patients, I have seen many of them are giving excuses because of the pandemic, couldn't walk over the road. So that's not the way to go. Definitely, the pandemic will be extending. So we need to be strict regarding this aerobic exercise as well as our diet style. Fitness is the foremost thing. And as we all know, sitting is a new way of smoking. So this is also giving a lot of new incidences of cardiac diseases. So they should, as already insisted by Dr. Anantharaman, so everyone should come forward to get vaccinated, whether they are cardiac patients. Most of the cardiac patients are worried that because of some rumors, cardiac patients should not have vaccines. I think every cardiac patient should get vaccinated, even they get COVID after 6 to 12 weeks of time. They should also get vaccinated. And post-vaccination, again, for minor symptoms, they put the blame on the vaccine. This is also happening. So non-cardiac chest pain, they are presenting it because of the vaccine. I developed chest pain. And nothing sort of things can occur with vaccine. You don't need to worry about. Some people Googled it out and find out that post-vaccination gives us clots in the veins. So I'm worried about getting vaccinated. So that's also false. So you should get vaccinated. It's a very strange incidence of blood clots post-vaccination. And if you don't get vaccinated, you cannot imagine what will happen. So it is better to get vaccinated and to keep fit, follow strict food style and aerobic exercise.
Thank you so much, both of you. I hope all the attendees will take your advices seriously, particularly with respect to vaccination, doctors. It was really nice talking to both of you. Thank you so much. Thank you.
Thank you, Pon. And thank you for Kauvery. Thank you.
Thank you.
Thank you, doctors. Thank you for this.